As we know that intrahepatic cholangiocarcinoma is second most common liver tumor after intrahepatic hepatocellular carcinoma, and it has poor prognosis with 5-year survival less than 5%. And surgical resection is the treatment of choice. However, it is possible only in the 20% of population because of various factors like advanced stage of presentation at the time of disease, poor hepatic reserve, or any other comorbidities. Systemic chemotherapy, radiotherapy as a primary treatment or adjuvant or palliative treatment has less poor response rate and high systemic toxicity. So whenever patient refer to us for the ablation, we usually reconfirm the diagnosis and maximum time required the biopsy. We also evaluate the clinical profile of the patient by knowing the liver function test, coagulation profile, and any portal hypertensive features and any associated comorbidity. We also look into the morphology of lesion to identify the ideal equipment used in each different location of the tumor. So indication of ablation include single nodular lesion less than 5 centimeter in size or less than 5 lesions each smaller than 3 or 4 centimeter where surgery is not possible or patient had post resection recurrence. At the time of ablation, patient should not have distant metastasis, vascular invasion, or any systemic disease. Ideal candidate are less than 3 centimeter in size tumor or patient with less than 3 in number of tumor. Absolute contraindication of ablation include progressive systemic disease, patient having septicemia, and uncorrectable coagulopathy at the time of ablation. There are some limitation of ablation based on either location of tumor, like if tumor is located on the liver capsule, then there is high risk of injury to the diaphragm or adjacent organ. If tumor is located near the vessel, then there is a chance of incomplete ablation. If the tumor is near the bile duct, then chances of formation of stricture in future. So we required some modification of our technique or so-called recent advances to take care of this limitation, like microablation or RFA with balloon occlusion to take care of the heat sink effect because of the near vessels. If we required large tumor ablation, then we may require cool tip electrode at the time of ablation. If lesion is not very well visualized on ultrasound, may require contrast ultrasound or CT guidance to accurately place the electrode. Our overall aim at the time of ablation is to achieve and maintain temperature in the range of 60 to 100 degrees centigrade within the tumor without damaging the adjacent organs, and it lead to complete necrosis of this lesion as well as adjacent rim of tissue equal to R0 resection of the in the surgery. Why we use ablative therapy? Because it is a very minimal invasive technique. It not harm the involved liver parenchyma, no systemic side effect related to ablation, no obvious morbidity and mortality related to ablation, and it is always a alternative to the surgery. Ablative method broadly classified in two ways: physical ablative therapy, chemical ablative therapy. Chemical ablative therapy, we use chemicals like ethanol and acetic acid, which usually used in past. In present era, usually use the physical ablative therapy. Physical ablative therapy either with the use of heat, cold, or electric. Heat used in the radiofrequency ablation, microwave ablation, laser ablation, and hypo. Cold is used in the cryoablation, and electric current is used in irreversible electroporation. What is the basic difference in the physics of the radiofrequency ablation and microwave ablation? In radiofrequency ablation, low frequency alternating current is used, which causes the generation of heat around the electrode. So this heat is then transmitted or in the surrounding tissue. So basically the generation of heat in the RFA is dependent upon the impedance of the tissue or the tumor. However, in the microwave, we use the high frequency microwaves which causes the oscillation of molecules in the tumor. So heat generation is occur in the whole of the tumor and not basically depend upon the impedance of the tissue. So advantage of microwave or RFA is that more uniform intra-procedure tumor temperature, no heat sink effect because of the adjacent vessels, we can ablate large tumor volume, we can use multiple electrode at the time in the same procedure, short ablation time, no need of grounding pad or skin burns, and less painful as compared to RFA. Here is an example where patient referred to us for the ablation and underwent MRI. This is the T1 phase axial section. We show hypointense lesion in the segment 8 showing restriction on diffusion weighted image, and this is the coronal image show that T2 hyperintense lesion reaching up to the porta. On arterial phase image it is showing settle enhancement. It measure approx 1.3 centimeter size. In portal venous phase we can see that this lesion is very well demarcated by small portal radicals, and this coronal section also show that the lesion is reaching up to the porta and nearby the large vessel as well as small portal radicals. So in this case very high risk of heat sink, so we plan to do microwave ablation, and this is the post procedure result. At 1 month follow up image we show T1 hyperintensity because of hemorrhage, no obvious any enhancement on venous phase, and these portal radicals are preserved. Coronal section also find no any obvious enhancement suggestive of complete necrosis. This is the 1 year follow up, show significant decrease in size of the ablation zone and no obvious recurrence suggestive of complete response. Based on location of tumor, there are two type of tumors: intraparenchymal tumor where tumor is surrounded by normal liver parenchyma, or surface tumor where tumor is located just near the liver capsule less than 1 centimeter size. Then there is high risk of injury to the adjacent organ. Like this is an example where patient referred to us for ablation, and this is the axial CT scan section. Upper liver cut show ill defined minimal enhancing lesion in the segment 4 adjacent to diaphragm as well as pericardium showing PET activity, and we use the microwave ablation with the setting of the temperature towards 60 degrees centigrade. So post ablation complete necrosis without any damage to the diaphragm as well as the pericardium, and this is the follow up PET scan, no obvious activity in this lesion. If lesion is near the vessel, then always a chance of incomplete ablation if we use the RFA, because in RFA heat is transmitted in the surrounding tissue, and because of continuous flow of the blood in the vessel which prevent the increase in the temperature in surrounding portion of the tumor which is nearby the vessel. So in this type of tumor we require additional modification, as in this patient referred to us for the treatment of this segment 8 lesion which is very minimal enhancing in the venous phase image, having broad area of contact with the right hepatic vein. This coronal section very well visualize that this have a wide area of contact with the right hepatic vein. So to prevent heat sink effect we plan to occlude this hepatic vein at the time of procedure, very well visualize on ultrasound. So place the electrode under ultrasound and simultaneously occlude the hepatic vein at the time of procedure. This is the follow up 1 month image which show no obvious any enhancement in the whole of the lesion, and this hepatic vein wall are very well preserved. This is the 1 year follow up which show significant decrease in the size of lesion, no any recurrence, and hepatic vein also very well preserved, suggestive complete response. Sometime tumor is located near the porta, then there is high risk of injury to bile duct. Is an example very hypodense lesion at the porta which is showing minimal enhancement, and this coronal section also see that it is extended up to the porta. So we plan the ablation with the setting towards a less degree temperature, and this is the post procedure 1 month CT which show that no obvious enhancement in whole of the lesion without any injury to the bile duct, and this coronal section also show that no obvious enhancement suggestive of complete response. Sometime tumor is located in the part of the liver where it is nearby the some adjacent organ like gallbladder, bowel or adrenal. Then this time also we required some modification, like in the example minimal enhancing lesion seen in the gallbladder fossa in segment 4 underwent biopsy, turned out to be cholangiocarcinoma, so we plan RFA ablation, and this is the very well visualized restriction on diffusion weighted image. Coronal section also show that this is very near the gallbladder. Place the electrode and start our ablation. When temperature is reached near the gallbladder, we aspirate the bile content from the gallbladder to prevent injury to the gallbladder wall. And this is the follow-up image which show complete non-enhancement in the whole of the lesion without any injury to the gallbladder. This coronal section also see that no obvious enhancement in the whole of the lesion without any injury to the gallbladder, suggestive complete response. Sometime tumor is also located in the part of liver where very vicinity to or nearby the colon, like in the example hypodense lesion seen in segment 6, which is very near the hepatic plexus of colon, which is showing very well visualized in the delay image. It is nearby the kidney as well as hepatic plexus of colon. So place the electrode under ultrasound and CT guidance to accurately place the our electrode position, and simultaneously we inject the saline in perihepatic space at the time of ablation to prevent injury to this hepatic plexus. And this is the post procedure 1 month image which show complete non enhancement in whole of the lesion without any injury to the colon. So literature also suggests good technical success and local control of tumor after the ablation, ranging from 88 to 96%. Disease free survival was 8.2 months and overall survival was 23.6 months according to literature. No obvious complication related to ablation. One of the meta-analysis published in European Society of Radiology in 2021, this meta-analysis included 917 patients and 20 of the 20 observational studies, and this study showed that technical success efficacy was 91% and 1, 3 and 5 year survival rate were 82, 42 and 28% respectively. Factor associated with shorter overall survival after ablation include tumor size more than 3 cm size, multiple tumors and patient having age more than 65 years. Another meta-analysis about the role of radiofrequency ablation in the treatment of unresectable intrahepatic cholangiocarcinoma. This meta-analysis included 7 retrospective study with 84 patients, and this meta-analysis also show 1 year, 3 year and 5 year survival rate range from 82%, 47%, 24%, and local tumor progression rate was 21%. One of the multicentric study published in 2019 about the role of intrahepatic cholangiocarcinoma, role of thermal ablation in intrahepatic cholangiocarcinoma. This study included 71 patients of intrahepatic cholangiocarcinoma, out of which 36 patients underwent treatment by RFA and 35 patients underwent treatment by microwave ablation. They further analyzed their data to identify the significant variable associated with overall survival, and according to univariate analysis, presence of cirrhosis, size of nodule, number of nodule and type of modality of for ablation, that is microwave or RFA, are significant variable associated with survival on urinary analysis. And on multivariate analysis, independent factor, 2 independent factor associated with survival, that is the presence of size of nodule less than 3 cm or more than 3 cm size, or modality used at the time of ablation. So if we use the microwave and lesion is less than 3 cm size, then there is good overall survival. This Kaplan-Meier graph of this same study show that overall survival was more in microwave group as compared to RFA group, and disease-free survival also more in the microwave group. They also analyze the subgroup analysis of the data according to size of nodule less than 3 cm as well as 4 cm, and in both size of lesions, microwave group show more overall survival as compared to RFA group. Another study published in 2020 about the role of thermal ablation for intrahepatic cholangiocarcinoma in patient having cirrhosis. In this study, 27 patients underwent thermal ablation. All patients have significant portal hypertension at the time of ablation, and according to the study, complete radiological necrosis was achieved in 92% patient. and median overall survival was 30 months and time to recurrence was 10 months. And significant factor associated with survival was less than 2 centimeter size tumor, so good response as compared to patient having more than 2 centimeter size tumor. And this study concluded that thermal ablation may be an effective treatment for intrahepatic cholangiocarcinoma in patient with cirrhosis. 11 patients underwent ablation in last 3 years in our department. Out of these 11 patients, 6 patients underwent RFA and 5 patients underwent microablation. Average size is 3.75 centimeter. Complete response seen in 82% patient and partial response seen in 18% patient. Progression-free survival was 12 months and overall survival was 24 months for 3-year data analysis. And I conclude my talk by saying that percutaneous thermal ablation is safe and effective treatment for patient with intrahepatic cholangiocarcinoma where surgery is not possible or patient who already undergone hepatic surgery. New thermal technology like microablation is useful in large lesion or lesion which are very near to the vascular structure. For safe and successful ablation, meticulous planning, exact localization of electrode and accurate placement of electrode is very helpful. Thank you.